Hey guys, so this would be our next lecture on the neoplasia, and this is going to deal with the carcinogens and the screening methods. And this would be the final of the neoplasia chapter, and by this we would be ending our chapter. Hopefully, you understand the neoplasia basics. Of course, we are going to see more detailed about all those carcinoma and the tumors in the respective chapters. Now, firstly, we are going to see the chemical carcinogens. Following it, we are going to see the radiation carcinogens, and in last, we are going to see about the microbes which are related to the which have the carcinogenic potentials. Okay. Now, the chemical carcinogens are usually electrophilic. Obviously, they should be electrophilic. Why? Because DNA is acidic, and after the DNA has donated one H plus ion, what does COO minus have? It has a minus charge, and because of the minus charge, the electrophilic chemicals are attracted to it, right? Now, the next thing is the that there is always a initiator chemical. Okay. Now, what's the idea here? The idea here is that whenever we have a population of cell, let's say we have 4 cell, now the chemical comes and destroys or mutates this cell. Now, this is the initiating mutation. Okay, not all the cells have been mutated, but now this cell won't divide itself. Okay, we need another chemical which is called as promoter, and the promoter will cause hyperplasia, that is the increase in the division of this altered cell, and that promoter presence is necessary for the tumor to develop or the tumor to progress. Okay, now this that's what I have written over here, that initiator chemical is tumorogenic. Now, promoter is not tumorogenic itself. If we apply only a promoter, probably there would be no cancer. But we need an initiator followed by promoter for the tumor to develop. And the promoter can be a hormone, as in case of the endometrium, when the endometrium hyperplasia is there in response to estrogens. And the promoters are also linked with the regenerative activity of the liver. Okay, so that's what I've mentioned finally, that initiation is caused by the initiator mutations. Then finally we have an altered cell, and now the tumor will arise only if there is a promoter. Okay. Now, chemical carcinogens are divided into two parts. Those are direct carcinogens and indirect carcinogens. Direct carcinogens do not require metabolic conversion, while the indirect ones obviously would require. Now, direct carcinogens, we have some famous examples, and one of the major example is alkylating agents. Now, why alkylating agents are important? Because it has a pharmacology tie-in. Now, what is it? Alkylating agents are direct carcinogens. Wait, but alkylating agents are also used in the treatment of leukemia and lymphoma and ovarian carcinoma. But alkylating agent have a predisposition to the AML or even CML, and this is the side effect, the long-term side effect of the chemotherapy. Okay, so Hyle, to keep in your mind that alkylating agents are associated with the increased risk of the chemotherapy-induced acute myeloid leukemia or even the chronic myeloid leukemia. Now, the next one is the arsenic, and arsenic is usually it's linked with skin, and you can recall that arsenic, even in the arsenic poisoning, we have something, uh, lines on the skins, in the nails and in the hairs. Okay, even after death you can see the arsenic poisoning findings in the dead person. So by this you can remember that arsenic is involved in the squamous carcinoma, cell carcinoma of the skin, and it is also linked with the lung cancer from the smoking. Now, the next one is the asbestos, and the asbestos is very high association of asbestos is that it is an occupational, obviously occupational, or even in some old homes also, when asbestos is used, that can cause asbestosis. And asbestosis is, can you recall, it is involved in the pulmonary interstitial fibrosis diseases, in the restrictive lung diseases. Now, it has a high association is that asbestos has increased propensity to cause lung carcinoma than mesothelioma. It causes both, but asbestos causes more propensity of lung carcinoma than mesothelioma. Now the next one, indirect carcinogens, and they require metabolic conversion, as I've already stated. They become to an active carcinogen, or what we call as ultimate carcinogen. Now the metabolism is by cytochrome P450, and it's dependent monooxygenase, and it is more important to understand that this is inducible enzyme, and being inducible, it also has polymorphic forms, and these polymorphic forms have the various examples we have for the polymorphic forms, that a certain group of population who have more CYP activity, they they have the more conversion to the carcinogen, and obviously then they would having increased risk of lung cancer. Okay, now we have some examples in the indirect carcinogens which are high to know. Benzopyrene, the first one, it is of historical importance because it is involved in it was discovered by Sir Potts, and what he found that soot from the chimney workers caused scrotal cancer, and obviously then they were advised to regularly bathe, and that reduced the cancer significantly. Now the second one is aromatic amines, and aromatic amines and azodides are usually found in the rubber industries. Those are also carcinogenic. Now the certain high yield to be aware of is alcohol. Obviously, alcohol is one of the leading causes of the hepatocellular damage or hepatocellular carcinoma. Okay, now, the alcohol can also cause the pancreatic carcinoma, and that's you can recall that the pancreas are basically that is pancreatic cars that is pancreatic sorry there's chronic pancreatitis from the alcohol, and slowly it may undergo to the carcinomatous conversion and may form a pancreatic carcinoma. Now alcohol would obviously damage the liver, and there can be cirrhosis, but there can also be hepatocellular carcinoma risk. Now the alcohol also is linked with the cancer of the upper esophagus and the squamous cell carcinoma of the oropharynx. So these are the high associations with the alcohol. Now the next one is the tobacco smoke, and the tobacco chewing can itself cause oropharyngeal cancers, and even the smoke can cause the cancers. Now tobacco, obviously, while smoking, the smoke goes to the lungs, so that would have increased tendency of the lung cancer. And the bad boys behind the main bad boys behind the tobacco smoke are the polycyclic hydrocarbons, and those particularly affect the lung. Now we also have something called kidney and bladder cancer associated with the tobacco smoke, and you can think that the once the polycyclic hydrocarbons enter the blood from the lungs, they go into the kidneys and they are filtered out, and when they are filtered out from the kidneys, they damage the epithelial those glomerulus filters, and in the bladder also, when those filtered out things are there in the bladder for some time, they would obviously damage the walls of the bladder. So that is the association of the lung, kidney, and oropharynx cancer with the tobacco smoke. The next indirect carcinogen are amines, and the amines undergo metabolism and they are formed as nitrosamines, and they are found in smoked foods. These are particularly seen in Japan because they have this smoked food, and with the smoked food we have association of the intestinal type of the stomach carcinoma. Now briefly saying, there are two kinds of the carcinoma. Those are the diffuse ones, and the another one is the intestinal type. We will see both of them ahead in our GI lectures, but for now it's sufficient to keep this in your mind that we have the association with the intestinal type. Now, the second one is the next one is the vinyl chloride, and that is associated with the angiosarcoma of the liver. Okay. Another important thing to be aware of is about the aflatoxin from the Aspergillus fungus. Now, the aflatoxin is particularly important because it was associated with hepatocellular carcinoma among the African population, and that was because of improperly stored grains and nuts. Those are affected by Aspergillus, and that causes the aflatoxin. Now, aflatoxin, what is the mechanism behind? The proposed mechanism is that it acts on the TP53 and it causes the non-functional TP53 or prevents its function to happen. And we know that TP53 is a tumor suppressor gene, so that would prevent the tumor suppression activity, and that's why that would lead to the hepatocellular carcinoma association with the aflatoxin. Now, radiation carcinogenesis. Particularly in the radiation carcinogenesis, we are going to see about the ionizing radiation and the non-ionizing radiation. Okay, in the non-ionizing radiation, we have the most important of them is the UV rays, and amongst the UV rays, we have UVA, UVB, UVC. But the UVA are not that much powerful in saying in terms of the wavelength and intensity, but UVC are most powerful, but they are also not of significant risk because they are removed or they are filtered from the ozone layers um, from the because of the geography of Earth. Now we have the UVB rays, and UVB rays, what UVB rays do is that they form the pyrimidine dimers in the DNA, and this is particularly important because these pyrimidine dimers are what cause the problems. Now, normally the pyrimidine dimers are repaired by the nucleotide excision repair, but if the non-ionizing radiation like the UV rays have more tendency to tilt the part to more damaging than the repair part, that would lead to the cancer. Now, the association with the UV rays are of the squamous cell carcinoma and squamous cell carcinoma, the basal cell carcinoma, and the melanoma of the skin. Okay. Now, you can you recall that one of the disease in which we have defective restriction endonucleus? Yes, that's xeroderma pigmentosum. And can you imagine what would happen in the xeroderma pigmentosum because of the defective nucleotide excision repair? Now that would lead to increased propensity of the cancer, the squamous cell carcinoma, basal cell carcinoma, and the melanoma because of the UVB exposure. Okay. Now, ionizing radiation, what is the basic mechanism behind the ionizing radiation is that it generates the hydroxyl free radical. And hydroxyl free radical cause free radical injury, and it damages the DNA. It has association with the DNA damage, and that would cause the defective DNA and hence increased propensity to the cancer. Now we have increased lung cancer among the minors, and this is from the historical point of view, which was because of the epidemiological studies which were done. So this should be in your back of your mind that minors of they were, I don't remember, but they were from Europe, I believe, had increased risk of lung cancer. Now the next one is the risk of the myeloid leukemia, and myeloid leukemia especially in the children, and even the papillary carcinoma of thyroid and the brain tumors, and from the ionizing radiation. And this was thought to be because of the increased CT scans among the children. So that is there. Now the skin, bone, and the GI cancers are particularly resistant to the radiation. Okay. Obviously, we know that skin is when we do X-rays or CT scans, the skin is exposed first, but still it's exception that it isn't affected by radiation, ionizing radiation. So this thing you can remember. Now the examples for the ionizing radiations are the Bloom syndrome and telangiectasia. That those we have already discussed in the previous lecture in the clinical uh, the clinicals of the neoplasia. If you have not watched them already, you can watch by clicking the card above. Lastly, we are going to see the microbial carcinogenesis, and this is also going to be very high yield discussion. Um, um, okay, the first one of them we are going to see is the Epstein-Barr virus. The Epstein-Barr virus is, can you recall where it is involved? Yes, it is involved in the infectious mono, and it is associated with the Burkitt lymphoma. Now, important thing to be kept in mind is that the Burkitt lymphoma, the African form of the Burkitt lymphoma, is usually associated with Epstein-Barr virus. So there are some cases of Burkitt lymphoma that are not endemic to the Africa, but still those are independent. Sorry, there are some Burkitt lymphoma that are independent of the Epstein-Barr virus. The second association is the B-cell lymphoma, and this is particular in the immunosuppressed patient, like in the AIDS or in the transplant patients. Now, the Epstein-Barr virus has also propensity to cause nasopharyngeal carcinoma, and like in Burkitt lymphoma, which is endemic in Africa, the nasopharyngeal is endemic amongst the Chinese males. Okay, now the next one is the hepatitis B virus and hepatitis C virus. The common mnemonic which sort of comes in my mind is that C for chronic and carcinoma. C is associated commonly with carcinoma and chronicity of the liver disease, and HBV is a DNA virus. And HBV, obviously, it's a DNA virus and is involved in the hepatocellular carcinoma. In contrast, HCV is a RNA virus. Still, both are involved with the hepatocellular carcinoma. The next one is the HHV8 human herpes virus 8, and that is associated with the Kaposi sarcoma. And that is Kaposi sarcoma. It's there in AIDS patient. But in AIDS patient, what we do to remove the Kaposi sarcoma is that we treat the AIDS. We put them on the antiretroviral therapy or high antiretroviral therapy. Okay, but Kaposi sarcoma is also seen amongst the transplant patient, and in the transplant patient, what we do is to decrease the immunosuppression. So from that, if we decrease the immunosuppression, our immune system wakes up and recognizes that we have something as like Kaposi sarcoma, and then goes to destroy it. Finally, the Kaposi sarcoma is also common amongst the East European males, and the it's a simple procedure to just remove the Kaposi sarcoma, and that is the treatment for the Kaposi sarcoma. The next one we have is the HTLV1 human T cell leukemia virus 1. That is the risk causes the adult T cell leukemia or lymphoma, and that is seen in the Japan and amongst the Caribbean population, and even in some parts of the South America, and some African population also. The next one we have is the human papilloma virus. The high risk viruses are 16, 18, and 31. Now, there are also some low risk viruses also, and they cause genital warts. But since they are low risk, because we call them low risk because they are less associated with cancer. So okay, so the 16, 18, and 31 are the high risk ones, and they are involved in the squamous cell carcinoma of the cervix, the anogenital region including the anus and the vulva. Then the adenocarcinoma of the cervix is also linked with the HPV. The last one we have is our bacteria, and one thing to be kept in mind in the H. pylori and even in the HBV and HCV, which I forgot to mention earlier, is that we have the main problem is that we have excess of inflammation. That is, the chronic inflammation is going to lead to the progression to the carcinoma. Okay, that's the case here in H. pylori and even in HBV and HCV. Yes, we know that there are different proposed mechanisms for them, but the mainly the chronic inflammation causes the more problem than the direct harm from the organisms themselves. Okay, so the H. pylori is associated with gastric adenocarcinoma, and with the MALT, which is the mucosal associated lymphoidal tissue, and that is because it has B cells, so it may lead to B cell lymphoma there. So we call it MALT lymphoma. Now, one more thing which comes in back of my mind is that can you recall that the HPV produces two proteins? One is E6 and the another one is E7. Now, can you recall that these are oncoproteins and where what they cause and how they uh, cause the cancer? Excellent. The E6 inhibits the P53 and the E7 inhibits the RB, that is retinoblastoma protein. So those both are tumor suppressor proteins, and that would cause them to produce cancer. So that is high association with the HPV and the tumor suppressor pathway. Now the another point which is important to be aware of is that the HTLV and HTLV and even the HBV viruses have what they activate is the NF kappa B pathway. Now, NF kappa B pathway is involved in the decreasing the apoptosis, and this decrease in apoptosis causes the survival of the cancer cell. Okay, so not very much high, but you can uh, include in your mind just for completeness. Okay. Lastly, we are going to see about the screening. Now, this is very important because we must detect the cancer or even the dysplasia before it converts into cancer. So, screening is necessary to detect dysplasia and to remove and treat the cancer before it advances much. The example for this can be the cervical squamous cell carcinoma of the cervix, that we detect the dysplastic cells when we do the pap smear before it spreads. Okay, and with that we have decreased a lot of the progression of the cervical carcinoma. Now, the cancer cell must undergo around 30 divisions before it produces any clinical symptoms. And with more and more divisions, yes, we know that there is Darwinian selection, and because of that we have more mutation and the cancer cells adapts more and more, and therefore it becomes more difficult to remove the cancer, or we lack those chemotherapeutic agents or even the surgical techniques to remove those cancers. Okay, so more the division, more the mutation, poorer the prognosis, and we cannot do anything. Okay, now the examples obviously with the poor prognosis would have those cancers that have that usually outgrow much, and those are ovarian cancers, because ovary is not surrounded by many structures. It is just in the peritoneum, and it grows and grows and grows before it produces any clinical symptoms. It is very large, and therefore it is linked with the poor prognosis. Even the pancreas also is not very much limited around it, and it causes the symptoms to rise. But there is an exception to this, because the head of the pancreas is usually detected early, because it produces the symptoms of the duodenal blockade. Now the lung cancer, similarly, we lack the screening methods, and lung cancer almost has very less 5-year survival rate. Okay. Now we are going to see very few examples of the screening methods which are very important to be aware of. Even clinically they are important, and they would come in your exams also. Now the pap smear. Now the pap smear is one of the methods by which we detect the dysplasia of the cervix. We are also looking for the cervical intraepithelial neoplasia CIN1 and CIN2. That involves that because of the if we detect the dysplasia, that would cause the detection of the cells before they convert to the cancerous state. The next one is the mammography. The mammography involves the ductal carcinoma in situ, and that is mainly the one thing which is to be done by mammography, and then mammography also detects the small tumors. Now, obviously, more the small tumor is, more better the prognosis, because it has undergone less divisions and it has lesser size, and then we have more treatment option. And we can also think that if it has a small size, then it might not have spread. So two things which we find in the mammography is to detect the ductal carcinoma in situ, and detect the size of the tumor, small tumors which are not detected clinically. Okay. Next, we have colonoscopy, and colonoscopy is involved in detecting the adenoma in the colon, and those have the adenocarcinoma, those also can be detected. Now, we usually try to find adenoma and prevent it to we remove them so that they are not converted to the adenocarcinoma. Similarly, we also have something called hemoccult test. It's nothing. We have blood in stool, and that may be coming from adenoma or from the adenocarcinoma, and that can be used as a screening method for the adenocarcinoma. Finally, we have the prostate cancer screening test. And can you recall that prostate cancer usually where it develops? In center we have urethra, then we have our here this, and prostate cancer develops in the posterior region. In contrast, we have the benign prostatic hyperplasia that develops around the central region, and that compresses the urethra. So BPH is very much detected clinically because it compresses and causes pain during maturation. Whereas in the our prostate cancer, it develops usually in the posterior part of the prostate, and that is clinically silent because it doesn't compress the urethra. So we have a very important screening method for the prostate cancer is the digital rectal exam, right? Now in along with the digital rectal exam, we also have lab studies like prostate specific antigen, which is supportive because the PSA can be raised in other things also, but biopsy is needed. The biopsy is a must, as I've already stated earlier in the lectures, that biopsy is a must for the uh, diagnosis of the cancer. Okay, so digital rectal exam is used to detect the cancer. With this prostate cancer, with this we have the concluded our chapter Neoplasia, and hopefully you have understood it very well. And now we would obviously see these topics again in the our systemic pathologies. Okay, for till then, bye. And hope you liked it. Subs if you loved it, please subscribe. Bye.